Good morning, everyone. The folks on Zoom right now pretty much know who I am, but I'm going to start with my general introduction. I'm Ruby Nguyen, and I work here in the School of Public Health, and I'm really very excited to have our invited speaker with us today. I would like to start with a land acknowledgement. I don't know if you all have noticed, but I'm sampling from different land acknowledgements each week, so we learn a little bit more and learn different things about the lands in which we work. So as a part of the University of Minnesota Twin Cities campus, the School of Public Health acknowledges that we reside on traditional, ancestral, and contemporary land of the Dakota people, land ceded in the treaties of 1837 and 1851. The 1837 and 1851 treaties were presented as mutually beneficial, masking their true purpose as a wide-ranging effort to marginalize or even exterminate Indigenous people. As a land-grant university operating on Dakota land, the University of Minnesota has benefited from commercializing this land, generating billions of dollars annually in economic and academic activities that have provided little or no benefit to the Dakota peoples. By offering this land acknowledgement, we recognize the sovereignty of Native and tribal nations. We commit to joining with Native communities in their traditional role as stewards of the land, and we stand willing to shoulder our share of the responsibilities in this regard. So welcome again. I'm so pleased that our invited speaker is with us via Zoom today. We were speaking earlier about how we would welcome a physical visit from her at a different time, but her schedule just wasn't able to allow it. So thank you all for attending via Zoom today. Dr. Deshira Wallace is an assistant professor in the Department of Health Behavior at UNC Gilling's School of Global Public Health, and a faculty fellow at the Carolina Population Center. Her research is focused on examining the effects of structural and psychosocial stressors on cardiometabolic disease prevention and management among U.S. Latinas in Latin America. Further, she uses an intersectionality framework to examine risk factors, coping behaviors, and chronic health outcomes, particularly among Latinas and Latin Americans of African descent, in an aim to further unpack health inequalities within the Latina and Latin American population. She works at the intersection of health sciences, social sciences, and the humanities to not only highlight health disparities, but also critically examine how these disparities and inequities came about. So welcome, Dr. Wallace.
Thank you so much, and thank you for University of Minnesota Division of Epidemiology and Community Health for the invitation. So there's a lot of slides to go over, and I want to make sure I have enough time, so I'm going to get started sharing my screen and start with the presentation. So hopefully you see the full screen, but if you don't, please let me know.
Yep, we need to switch again.
We need to switch again? Okay. Sounds good. Okay, so thank you again for inviting me. So today I'm going to talk a little bit about my work in the Dominican Republic. It's focused on stress, anxiety, and kind of thinking about psychosocial factors and its role in diabetes management in rural communities in the Dominican Republic. So there's a roadmap for today. There's several papers and parts of this study. It started in 2015. There's never been a grant associated with this study, actually. It's come about with cobbled together student funds and postdoc funds and other small grants. But we've somehow been able to kind of see how it's evolved and see kind of also from the community what it is that's most important to them and shift this project over time. So we're going to talk a little about the social support aspect of diabetes self-management that most people generally know, but thinking about it from the perspective of adults living in a rural area in the Dominican Republic, thinking also about stress and coping with diabetes self-management, thinking about provider perspectives and how they feel about addressing emotional health and diabetes care, and then also diabetes distress in the Dominican Republic in general. So there are some overarching study objectives that we had over time. One was to understand and explore how adults with type 2 diabetes, Metellus, managed their condition in rural communities in Dominican Republic. Also to understand in parallel how physicians, nurses, and community health workers treat and manage type 2 diabetes among their patient population. So in terms of the study background, the work I do is in this central part of the Dominican Republic. So when I say I'm going to do work in Dominican Republic, everyone's like, the beach. And I'm like, no, I'm in a central part of and it's a very rural agricultural region. It's where we have the cacao, the rice fields, and that's kind of most of the economy there. And when we think about the Dominican Republic, why did we decide to do some work there when it comes to type 2 diabetes? Well, the prevalence, it's a bit variable depending on the source, but it's about 11% of adults who have type 2 diabetes, but it may be closer to 15% for those who are undiagnosed. And so we really wanted to understand what is the experience of adults who have type 2 diabetes or who have been diagnosed and are aware that they have type 2 diabetes, and also are able to possibly seek some sort of care for their condition. Oh, and sorry. So we also worked with 2 clinics. One clinic had, at the time in 2015, 500 patients, and the other clinic that's close by had about 450 patients enrolled in a diabetes and hypertension management program that was led by an NGO and a nonprofit. The NGO is in the Dominican Republic and the nonprofit based out of Iowa. That really just focuses on providing medical care, medicine, and community and health education to adults. So this is the timeline of our projects. And so the first ones I'll talk about are from the 2015 data collection. I went down with a colleague and we did qualitative interviews to really just understand what it means to live with type 2 diabetes in a rural area, and also thinking about the health transition from infectious to more chronic disease from the perspective of community health workers. I'm not going to present on that study yet. That paper is actually still in process, but we're going to focus thinking on the living with type 2 diabetes piece. And we went in with no preconceived notions. We were just trying to understand their lived experiences and the narratives in which they were able to share with us. So our team went down summer of 2015, and we did recruitment across 3 areas in the 2 clinics. And so we would go every morning or afternoon and ask participants if they're interested in being part of the study. And before we did this, we worked with the clinic team, the community health workers, to ask them and have them actually review the in-depth interview guide to make sure our wording makes sense. It's the first time I was working in the Dominican Republic, and so the team, while I'm originally from Panama, and the other teammate, he was Mexican American, we spoke Spanish, but there's different ways to express some of the similar ideas, and so we wanted to make sure that they were on board with how we were framing questions, if they found any of the questions to be a bit overstepping. So we made sure to brief our clinic team beforehand, and so they would also then brief their patients beforehand and before they saw us, and also over the course of 2.5 months where we did data collection, to make sure everyone felt comfortable, and also to ensure that you can participate. It's not a requirement for their care. We also recruited in homes. So some participants or some patients weren't able to come to clinics all the time. And so and also in some rural areas, it was harder for them to get to these clinics. So on occasion, we would go into some of the more further away towns and see if anyone was interested. We would kind of talk to them in their homes. And then the clinics were often just 2 or 3 rooms, and there would be a local church or school that was nearby that was open and empty at that time. And we would work with them to provide another space that was private for participants to come and talk to us for 45 minutes to an hour. For the 2015 data collection, we ended up doing 49 semi-structured interviews, about 30 of which were with patients with type 2 diabetes. We interviewed actually 30, but one had hypertension and not type 2 diabetes. We also interviewed community health workers and 5 providers who are nurses and physicians as well. And we interviewed the community health workers twice, actually. So there were in total about 16 interviews with them because we wanted to understand their experiences over time. And they've been working in the community for, on average, 20 years. These are just some basic participant characteristics, and these are specifically for the patient. So I'm going to provide mostly a patient participant data from these few studies. And the age ranges are about the same, education, primary school about the same, number of years with self-reported years with type 2 diabetes on average about the same. So things were very parallel. Most individuals were cohabitating with a partner, either married or a union. Some were widowed, separated, but in general, it was about the same across both clinics. In terms of the methods, after every interview, we conducted field notes about how things went, what were the dynamics of the interview, what were some of the themes we were starting to see, or what were some things that were surprising, what things we could do differently. One thing that came up was my colleague who went down with me, we ended up talking a lot about, there was some things that came up for the men about kind of how type 2 diabetes impacted kind of their sexual performance, which I was like, they start talking to me about that regardless. It wasn't really an issue, but they maybe talked to him a little bit more. So we ended up doing some sort of gender matching halfway through, just to make sure we were capturing everyone's experiences as comfortably as possible. After doing field notes, we did audio record everything, and so we transcribed the interviews ourselves, or worked with Dominican professionals to transcribe the interviews verbatim, making sure we kept it actually within the same intonations and the way everyone spoke. We read and reread the transcripts. We took notes on these transcripts or memoed. We developed a code book, and then we coded using Atlas TI to look at what exactly was happening. And then from there were a lot of themes. So there's going to be several papers from this initial set of data, but we started constructing what are some of those themes that we were seeing kind of across participants, across individuals. And so one of these papers is about social support and type 2 diabetes management. So this is the first paper that came out from this. And while wading through the data and also thinking about the field notes and our own observations, one thing I was looking at was, okay, we understand what social support is, there's social support theory, correct? And so using social support theory, I framed kind of what the paper was going to be about. So how do participants talk about emotional support, informational support, instrumental support, appraisal? And so for emotional, having someone who can like talk to someone, that was often what individuals talked about. Informational, letting someone know about the clinic. Instrumental, providing something tangible, so money, transportation. And appraisal, sometimes letting you know or giving you some sort of feedback. So that was actually the simplest part. But when I was doing the analysis, I used a narrative type of analysis. So I actually wrote out for every participant, the 29, what was their experience with type 2 diabetes from beginning to end, or beginning to that moment in time when we talked to them. And everyone spoke about it in this linear way, over time. So diabetes diagnosis, linkage to care, and self-management. Those were kind of the 3 stages that I started seeing. And then across those stages, there were different types of social support, but also different sources. Who did it come from? Was it family, friends, neighbors, peer, and the clinic team? Those were kind of the big 5. But I was realizing that these varied over time. So for example, with diabetes diagnosis, there was very little or limited social support type. So participants mostly mentioned, I was diagnosed because I already was going to the clinic for something else, or I didn't feel well, or happened to go to a community screening. And so it just happened there. So it was mostly like self. So there was no additional forms of support. But there were potentially some appraisal support, and I'll give you an example of that shortly. And so the source, if there was some sort of appraisal form of support, it came from a peer or a neighbor. It didn't come from someone in the family, or at least it wasn't said that way. And often probably not from the clinic team because they hadn't gone to seek care at that time. So one example of appraisal and coming from a peer or neighbor was in this example by a 53-year-old male participant. He mentioned, my neighbor told me you're sick, your clothes are loose and falling off of you. I agreed. I had a t-shirt that no longer fit, sickle, which means dry or feeling shriveled up. I was getting sickle to the point that a man told others, be fearful of that man, he could have AIDS. And I heard that, you see. I went to my partner and told her that I felt ill. After that, a neighbor took me to see a good doctor to see about my condition, where the doctor then tells me, sir, you are a diabetic. So this one had several. It included first the neighbor kind of stating, you don't look so well. Then also hearing from others kind of their assumptions about why he didn't. And then there's also the neighbor who actually provided tangible support to take him to see a doctor. But it was often no support at all, or no type of social support at all during this initial diagnosis stage. The second was linkage to care. This one really, the types of support tend to be informational and instrumental. Someone told them about the clinic or the program, and someone took them to the clinic or program. And often this came from peers, family, coworkers, and neighbors. And an example of this is, so how did I first get here? This participant said, the man sitting in the waiting room brought me. He found out about this program and invited a group of us to go with him. Every month, a few of us go in his bus for our appointments. So someone telling you about this program and then also offering you a ride. So this was not uncommon in terms of the types of support that we were seeing at this stage in terms of linkage to care. One thing that was surprising me for the first two was, I mentioned here family, but family was actually really, really low, even to linkage to care. It was often more so the case at the last stage for self-management that we started really to see family, specifically partners. So in this stage, it was a lot of informational support, instrumental. You'll see also that emotional wasn't really big across any of these three stages. And that does have implications, I think, for studies later on. But the source came from family and also came from the clinic team. You're already there. The clinic team has mostly community health workers, and they provide a lot of educational, informational types of support, and also sometimes emotional support too. So this participant, the reason I have an asterisk for partners is because we did see a difference between men and women. And so for men, we see there is a lot of kind of positive social support. So this participant mentions, yes, my wife supports me with my treatment. She'll give me what I can or should eat for my diet. If I can't eat something, she does not prepare it. That is lovely, and I wish that happened for everyone, but it didn't. When we spoke with women, especially if they were the only people in their family with type 2 diabetes, it was kind of the opposite. They felt very alone. If they had a partner and their partner also had type 2 diabetes, that's actually when they felt supported, because both of them had to change some aspects of kind of their lifestyle. But if you were alone, as this participant mentions, it's very lonely. So she says, no one supports me, no one. How do I say this? Even if I feel bad, no one pays attention. Not even my sisters come to visit and lend me a hand. But God gives me strength because no one else helps me. Listen, those of us who have diabetes have to be careful. So they need someone who will support them so that they feel better. And this was not an uncommon kind of feeling. And so kind of the big picture results from the 2015 study showed that type 2 diabetes the narrative was that it manifests differently across time, from diagnosis through management, and by who provides support from self, family, friends, and neighbors. These results helped our community partners actually develop a patient association, which was targeted towards improving social support, especially for women, because we were seeing, and we were able to let them know that there was some unbalance happening with their patients in the clinic. So it did actually end up creating a different program and a different setup in the community clinic. So when we were starting to hear a lot about stress too in the narratives, in these interviews, and we're trying to understand, so where does it come from? And we can make assumptions and we can make observations, but it was nice to hear from participants about kind of where these different dimensions were coming from. And they came from multiple, as stress does. And so often it was interpersonal relationships. And I just gave you an example with when we spoke with women who felt like there was no support, that was causing a lot of stress and also kind of depressive symptoms as well. Physical health, diabetes itself causes stress. Managing it causes stress. Other health-related issues cause stress. Emotional health, so individuals were stressed about the idea of being stressed. They were stressed about the potential of being depressed. So there was a lot of that. Injury susceptibility, there were different individuals who were talking about how I need to be really careful, I can't cut myself. I have to be really careful about even just cooking and doing these different things. I can't get sick. And that was also tied to economic security. Can I still do the work that I do both inside and outside the home? So can I, clean my house? Can I do the things I need to do? Can I do these one-off jobs? Can I keep the job that I have? And so there was a lot of stress around uncertainty with kind of how your body can fail you at different times. Also, there was this idea about diabetes and pique, which is a term that they use a lot in the Dominican Republic to explain kind of anger or feeling hot-headed. And so there was this idea that people with type 2 diabetes can't get angry. They can't have some sort of emotional deregulation. Well, there's two ideas. One, that people with type 2 diabetes are hot-headed. There was that one piece. And then you have to maintain calm at all times, because if you don't, it's going to increase your blood sugar. And so there's stigmatizing ideas about what it means to have type 2 diabetes as well. That you can't control your emotions. And so that came up a lot. So that was like another stressful piece of like, how do I manage this condition? And also this idea of everyone assumes I can't manage my emotions too. So given time, there's only a couple examples I'll have on each of these forms of stress. So for economic security, this participant mentioned how diabetes is just harder for the poor. And so she mentions diabetes is harder for the poor. I would say it's much harder. I feel bad for those of us that suffer from this illness. Sometimes I go to sleep hungry, and more so when one lives in the countryside. Things in the countryside are very difficult. So I mentioned that this is an agricultural area, but one of the difficulties was, and one of the disconnects was, they have a lot of rice, they have different tubers and things like that everyone eats. But they're also being told you can't eat that, or you can't eat it in the amounts that you would typically eat it. So I think they're able to change it in terms of amount, but sometimes getting told, well, you can't eat white rice, eat brown rice. Where can someone find brown rice? There isn't like a grocery store super nearby, and it costs a lot of money. So there's this idea of like, what can I eat? What, even with the things that I have, it's not enough. And so there's a lot of, in terms of food insecurity, but also general economic insecurity. And this is an example of the emotional health piece. So participants mentioned a lot that living with diabetes is worse. And it's even worse when you think about it. It's worse because you can die from depression if you think about it or think about diabetes. And it can also affect your heart health and all of that. So there's an idea that if I think about diabetes, I'm going to get myself to feel worse, which is actually one of a next study that we ended up talking about. So kind of big picture from our 2015 data, we talked about social support, but we also thought through the sources of stress and how they come from these different dimensions. and that there's a bigger issue here about diabetes related stress or diabetes distress that we were starting to see in 2015, but we're trying to figure out what else is going on the psychosocial mental health side of things. So that led us to do some additional work to think about the mental and emotional health of managing type 2 diabetes. Again, we came into this in 2015 without any preconceived notions. And so this just came through, and we wanted to make sure we spent time talking to patients about it. So we went back down in 2017, and we specifically honed in on patients only to ask them about their perspectives on mental health and the emotional health of managing their type 2 diabetes. So for recruitment, we did about the same home clinic as well. And we interviewed 20 additional participants, all with type 2 diabetes. They had similar characteristics, so I'm not going to go into that. And we did similar things for the data analysis again: field notes, transcription, reading transcription, memoing, code books, coding, and constructing themes. And for this piece, we actually end up using this colloquial phrase, no le doy mente. The long version is no le doy mente a eso, so I don't think about it. And so it's a colloquial phrase used in the Dominican Republic, but also in a lot of Caribbean areas, of just, you're not going to dwell on something, like, and you can say it in any sort of circumstance. And we heard it a lot in our interviews, but then we actually went back in 2017 and probed on what does that mean, and also what does that manifest as. And so participants talked about how when they felt different stressors, they can cope in two different ways when they talk about no le doy mente. It's either they are actually coping with whatever the stressor is, and that includes type 2 diabetes, or they completely disassociate because it's too much to think about. And so for the coping side of things, I take this as individuals learn about the behaviors that they need to do, or the things that they need to change, or have access to the medications that they have. So at this point, they're on autopilot. They don't have to think about diabetes like cognitively, because they know what they have to do when they wake up in the morning, throughout the day, when they go to bed. So they're just on this autopilot space. So as this participant mentions, I would say learn how to manage what you eat. So changing some parts of their behaviors, learn how to manage your situation of sugar, your diabetes, and don't think about it. Always have your mind busy with work and exercise. Diabetics shouldn't just sit. So for her, she was talking about, like, just basically understand what your daily habits need to be, change them, and that's difficult. But once you do that, you don't really have to overly think about it. That was the majority of participants. However, there were a not so insignificant number that mentioned disassociating kind of completely. And so for them, they thought about no le doy mente as, I would say, the less you think about diabetes, the more you can control it, because you know that with diabetes, the more someone worries, the more their sugar rises. And if you're peaceful and tranquil, you can control your sugar more. This kind of relates to this idea that I mentioned of pique, of just this idea of you have to stay calm. And so participants, when we probed additionally on this, they mentioned, if you think about diabetes, you're just going to ruminate on it. And ruminating on it means you're going to be depressed, and you're going to die because you got depressed. That is literally kind of the stages that they talk through. And so they just figured, just do what I can, but I'm not going to think about my diabetes almost at all. And so those were the minority, but still a way that individuals, when they say no le doy mente, there were these two different ways of thinking about it. So this paper came out in 2019, and so it kind of goes into a little bit more, but those were kind of our two big results in thinking about this colloquial phrase that happens every day, but you wouldn't notice, but really digging through, like, what does it mean when you're talking about this with chronic disease management, and that it can manifest in this coping autopilot kind of way, or dissociative way of not wanting to think about it because you could get depressed. So we talked about our patient participants and all about their experiences living with type 2 diabetes. What does it mean to have social support or not? What does it mean when they actually are thinking about management of it? And in the end, they're working closely with this small but mighty provider team. And when we think about providers, I'm meaning community health workers, the nurses, and the physicians that are there. And so we wanted to go back and ask them, so we've shared this data with you, we've done workshops with you. What are your perspectives of providing emotional and mental health support for your patients? Because we can suggest things, but how do you feel about that? So we went and did semi-structured interviews with 14 participants. These were the physicians, nurses, and community health workers. We interviewed a couple community health workers twice. So there's 3 providers, 3 physicians, 2 nurses, and about 5 or 6 community health workers. And there were several great quotes, but I think this one showcased a lot of what they go through every day and what they understand ultimately, and they're very much in parallel with, we know that there's a lot that needs to be done to work with our patients. But they mention in a day-to-day, as this participant mentions, and I don't say who they are because it's such a small team, that we are the patient's mantle of tears. As I always say, the doctor is more of a counselor than a doctor. If we have 100 patients, all 100 will need some form of counseling. A patient cannot improve if you do not look at what's going on with them emotionally. So they're aware of, there's the link. They also are aware that their job is maybe outside, what they may need to do is outside the scope of their job. So when we talk to providers, they mentioned, we need training on this. We weren't trained on this. The community health workers that work in the clinic now used to work with mothers and babies to work on undernutrition and things like that, and mostly maternal child health outcomes. They got trained to work with adults with type 2 diabetes in 2010. But there was no, and then the providers are family medicine doctors. And so there isn't that much training on mental health and things like that. And it's important and they're aware, but they mentioned, one, not all of us are qualified to do this. Not all of us have the disposition to do this. There's some providers who are more patient and can think through this and can answer questions in a way. And also we just might need support. And so that includes maybe having a referral system or having a counselor come in a couple times a month to actually address the needs of some of the patients too. And so kind of big picture results from this one, and this paper just got accepted last week. And so providers really understood the implications of the emotional burden of type 2 diabetes on their patients. So they're just they're on the same track, but they did feel that, again, some providers do actually have the characteristics needed to provide emotional support. Not everyone also wanted to. And I think that was really important. Providers acknowledged that they needed additional training because they don't always know where to start. And they suggested having increased resources. Again, this is a community clinic. That is, everything that they get is donated, or it comes from small funds from a nonprofit. So everyone gets a salary, a modest salary. The medications are free for patients and the appointments are free, but all of that is from donations. So resources are really tight. But if there's ways to increase resources to improve care for patients, that would be a next step. So all of this information was kind of in my head for a while and trying to think about, so we're knowing that there's stress related with type 2 diabetes, but we don't really know where a lot of it is coming from. We have a lot of qualitative information, and that's really lovely. But can we figure this out quantitatively in some regard? And I thought about, there's a diabetes distress scale that's been used in the United States for a long time, and it's also been translated in different places, in Spanish in different places. And so I wanted to use it in Dominican Republic, but I was realizing that it doesn't really work all that well, but I couldn't figure out why. So I thought about doing cognitive interviews, which is another qualitative method with the aim of doing a quantitative study this upcoming year. So the goal was to do cognitive interviews to understand diabetes, this diabetes distress scale within the context of the Dominican Republic. And I wanted to kind of go back a little bit and explain what diabetes distress is. So it is this idea of frustration, anger, overwhelm, depressive symptoms related to the difficulties of self-managing type 2 diabetes. And so these were all words that were coming through across the many years. And so I figured, can we actually measure this in a way that's helpful, not just as a research project, but actually back to the clinic team so they are aware of where is this distress coming from, and they can actually adjust their clinic time to address some of that. And the diabetes distress scale was developed in the United States, mostly in VA hospitals, Veteran Affairs hospitals, and in a couple diabetes-related clinics. And it's 17 items. It measures kind of the difficulties or hassles of managing type 2 diabetes. So it includes managing like the interpersonal relationships, the regimen, the emotional components. And so these are really kind of some of the key pieces we were trying to understand. And for me, I wanted to ensure before we apply the scale, I wanted to make sure everyone understood the questions correctly. So it is a scale kind of adaptation project. And I try to do this using cognitive interviews. So again, it's another form of a qualitative method, but it's really focused on assessing scale and item structures, making sure that participants can improve participant participation, improve an understanding of a construct or a phenomenon. So I really want to make sure, do participants actually understand what I'm asking them? How easy is it for them to respond, or is there a lot of cognitive burden? And also, are they actually responding to what I think they're responding to? Because if you don't ask those questions, everyone can answer a Likert scale. You just don't know if they actually are conceptualizing what you think they could be conceptualizing. So I wanted to ask those questions as well. So why did I choose to do cognitive interviews in the Dominican Republic? Again, based in the United States, there are Spanish versions. So I could have just used the Spanish version, but it wasn't assessed in the Dominican Republic or even the Caribbean. So there's a Mexican version, Central American, Argentina, or from Argentina, and also Uruguay. So great, but not necessarily one-to-one, and also one from Spain. And so I felt like if we didn't do some testing, we could inadvertently introduce bias into our quantitative data collection, but we just wouldn't know the extent of that bias. And so I decided to go down again in 2020, and I did this verbal probing method, which is essentially a semi-structured interview where I would ask, so I interviewed in total 20 participants, but I did this in an iterative way. I interviewed first 5 participants in this first round with the scale as is, the Spanish version scale as is, just to understand what were the major points of confusion. Were some things happening? Was it hard to answer questions? And then I would take a lot of notes after each one. And from those notes, I did a second round of 5, where I asked participants for alternatives to clarify any of the questions or the items that were causing some confusion. So I was starting to basically crowdsource different phrases that would make sense. And then in the third round, I interviewed another 5. Again, after using like kind of extensive field notes, I began adapting items against the original. So I would keep the original question, but then I would write another question that adapted maybe a phrase to see, one, if it was easier or not for participants to respond. And this was like my perception. Were they able to respond quicker? Were they still delayed? Did they understand what the question was about? And so I did that in round 3 for like the 11 to 15 people. And then in round 4, I continued testing and I kind of clarified and followed up on any structural changes. And so by that point, by the time I got to maybe 16 or 17 people, there were no changes, but I kind of rounded out just in case to 20 participants, and there was no new information, so I stopped interviews. I also did this from February to March 2020, so I luckily had a really good pace, but I had to cut my time short by 3 or 4 days because I think the Dominican airport was closing down because of COVID, and I was in a rural area and I had no idea COVID. I knew it was happening, I just didn't know to the extent because I was just away. And so when I did the analyses for this, there's a theory of cognitive interviews from Roger Torongo to think about comprehension. How do people understand the question or understand the phrases? Recall, what information do you need to give them for them to kind of in memory recall the right information to answer it? So if you ask the question of how many times in the last year have you gone to the doctor? That sounds really simple, but individuals may have to think last year as in from today, 12 months ago, in this calendar year. By doctor, do you mean my PCP? Does that include emergency room? So are the questions helpful for me to recall a proper response? In terms of judgment, or bias, it focuses on the clarity of the question. How clear is it for individuals to be able to respond properly? If it's confusing, there could be some introduced bias in that. And then we also are interested in the responses themselves, if it's a Likert scale, if it's open-ended, if it's dichotomous, yes, no. So we want to understand, does the response make sense with the question or the item? And then larger structural issues. So for me, that was the introduction of the scale and just how the questions were arranged as well. So I did all of those. I also, as I mentioned, I was trying to keep note of how easy or hard it was to answer the question. So I created a matrix where 0 was they did not answer the question at all, had major difficulty. 1 was, and also I included the instructions themselves. So that was a structural piece. Did they understand the instructions? Was it easy for them to follow? So if it was 0, no, it was really difficult. 1, there was some difficulty, and 2 meant that they were able to respond quickly and understood with very little kind of perceived cognitive concerns. And so this was for me an easy way to kind of see it in real time of, oh, this question might be a problem, or this question seems like it's going pretty well. So I just have a snippet of the first 12. I have the full matrix of all 20. So with that, I was able to make some adjustments. And so I have examples of some of the adjustments that I made. In total, about 3 items had low comprehension. So I have this original Spanish version and I have an English version so you can read and understand, but I did, but these 3 questions, for example, the first one, which was related to not feeling like I can test my blood sugars frequently enough, there was a huge issue with understanding the phrase analizando la sangre, so testing my blood sugar. So 9 out of 20 participants had difficulties with that. And I asked them, what do you think that means? And it was just a range of understanding. So it was just like, I feel like I'm not necessarily, it felt like some of it was blood sugar, but most of it was getting diagnosed with type 2 diabetes. Others were about failures with having type 2 diabetes. So it ranged. So because I saw that it was not very clear, I noted that this is one to change. Similarly, the next 2 had issues. This one had 16 out of 20 participants with difficulties. First of all, the word régimen, which is regimen, was just not good. And so these 2 questions both have régimen de diabetes, or the diabetes routine or diabetes regimen, was very difficult to understand. And so participants either could not respond to the question at all, or they also thought it was like a moral failure that they had type 2 diabetes. Like it was just a very different interpretation of what it meant. And of course, if I didn't ask these questions, I wouldn't know. They would still respond to the Likert scale. It's just, I wouldn't know what they were responding to. And the last one, about 9 out of 20 participants also had difficulties with the phrase régimen dietético saludable, which is feeling that I'm not sticking closely enough to a good meal plan. the English version is a lot easier to understand than the Spanish version, because it's a dietary regimen, which nobody understood what that meant. And so I asked them, what do you think it means? Again, it ranged. And so I asked for all of these if there are other phrases we could use. And so let me make sure. So here, these are the Spanish changes, and these are all based off of their own ways of talking about it. And when I tested these with the originals, there was very little resistance to be able to understand what I meant. Like, they're very clear, oh, I'm doing a blood test, or yes, I'm like actually doing my dietary regimen or my recommended dietary behavior, or I'm kind of controlling my blood sugar. So those were a little bit easier. Also keeping track of time. And so for judgment, these are about bias. Do people understand what you're asking them? These didn't have an issue necessarily with understanding, but what I noticed was these are double-barreled. So there's two things I'm getting asked about at the same time. And participants were mentioning how they felt like when I asked them about, like for the first one, feeling like diabetes is taking up too much of my mental and physical energy every day, they only answered half the question. It was only about mental or physical energy, not both. I asked them separately, and I had different responses. I realized they weren't averaging them out. So in the end, I decided to split it. I also decided to split this other question about friends and family don't appreciate how difficult it is with living with type 2 diabetes. So it ended up being a little bit needing to split some of these because I was realizing they were not answering the full question. For recall, the only major concern was relating to the response options. It's 6 levels for a Likert scale. It was a lot to remember, and we're applying all this verbally, so no one's going to remember the different levels. And so this related to the next one on response options. I asked participants, if they could distinguish between all 6, and there were some that they were like, no, we can combine because I don't know what moderate problem and a somewhat serious problem is. Like, they sound the same. So in the end, I combined 2, and I was able to reduce it to a 5-point scale. And then lastly, the instructions were long. It was 2 paragraphs for verbal application. So I reduced it to a 1 paragraph. And I added a question to make sure that they knew, oh, are you ready to get started? Because I was realizing individuals were starting to talk about a narrative before we even got started with the scale. I wanted to do that to improve clarity. So very briefly in terms of next steps, these were all qualitative, and I thought these all build on each other. But in terms of next steps we want to use our information to inform the quant study. So the scale has been revised from 17 items to actually now 19 items. And the goal is to go in the summer of 2023 and apply this adapted revised diabetes distress scale to the entire clinic population, which is probably closer now to 1,100 people. And mostly the goal is to assess the level of diabetes distress with this scale and making sure if it's viable for use in the Dominican Republic, so doing psychometric analyses, but also because we know participants were talking about depression and anxiety and how stress made them feel like they were anxious, we can't differentiate these, so we wanted to ensure we have a larger questionnaire that accounts for depression, anxiety, and other forms of stress, and also account for maybe some of the structural factors like economic insecurity or food insecurity as well, to understand some of the structural and contextual issues happening in their daily lives. So that is the goal, is to do that in the summer and try to get some of this information, also share it back with our partners so that they understand what's going on with their patient population. And so very quickly, just wanting to again thank you all for inviting me. You're welcome to email me about any questions. I wanted to thank everyone on the team who's worked with us over time, and it's been a great project. So happy to answer any questions, and also happy to stop sharing screen so I can see everybody.
Dr. Wallace, that was excellent. I'm so very glad that you were able to take the time to come visit and speak with us today. As Dr. Wallace said, she is open to questions, and we welcome those now. People are getting their thoughts together.
Yeah, it was a lot of information. I'm also happy to talk about any questions you have on methods of doing these or community engagement in general.
I'll ask a question. So I'm wondering, thank you, it was a beautiful presentation. I'm wondering how different or similar you think the struggles or the challenges that this population faces are to what other people are facing. Yeah, like here, you know.
No, that's a good question. So actually, our partner, Chronic Care International, CCI, is the one who created the diabetes and hypertension program. They have a similar program in Iowa, actually. And the group in the Dominican Republic, their A1C levels are controlled at a much better rate, actually, than the group in Iowa. So they have basically a comparison. But there's some things that aren't quite, there's some contextual issues that we can't really account for in the Dominican Republic. For me, I think a lot of it is the same. So the literature is really helpful to be like, there are parallels, but there isn't that much information on the Dominican Republic about what's available to help that population, at least even with working. My goal is to work with the government at some point. I worked recently on a study with Dr. Katie DeRose, mostly works with HIV patients. And I was interested in people who live with HIV and a chronic condition, and to see how do they feel about managing both. And so I'm resubmitting this paper right now, but HIV was a lot easier because there's actually government resources in the Dominican Republic. They actually have a referral system, they have government clinics, and they're like, yeah, once I have a medication, I'm good. I don't have to do anything else to change. Like, I don't have to change my lifestyle in such extreme ways, but there's nothing similar for cardiovascular disease and type 2 diabetes. So they use the emergency room if they can get there, if they have money, which is very similar here. But thinking about it from like a governmental standpoint, that there isn't really a referral system. I think they need information. And so for me, it's more so like, how do we support governments to think about changing the healthcare systems?
Have you been involved in many conversations with the government in the DR?
So I am working with their public university and their school of public health to talk with them about this. So with this project, it is part of the Institute for the Institute for Latin American Concern, which is a Dominican NGO, which is also Jesuit NGO. And they actually don't want to engage with the government. They're trying to fill in the gaps. So we've been trying to see, like, can we share lessons learned? And we can, but they don't really want to engage with government clinics that are actually also nearby and managing more than just type 2 diabetes and hypertension. And so, but CCI, our community partner in the United States, is like, oh yeah, we do want to engage with the government. So it's figuring out ways to ensure we can engage. But I am working kind of outside of that, working with universities there, public universities that have ties to the government too, to figure out what are ways that are feasible to engage with government clinics and with governments in general there.
Well, others are thinking of questions. Dr. Wallace, I would like to ask a tangential question, if you don't mind, and I'll give you some time to think about an answer, because I know it's not perhaps at the forefront of your mind right now, but I totally agree with Dr. Dumont-Steiner, who is our division head, in asking and saying that this was a beautiful presentation. And one of the things that stood out to me that made it so beautiful was that you are multilingual. And so as I think about, as in my roles as an educator, the role of a public health workforce that is multilingual, I think of the challenges that we have currently in being able to provide enough resources to our students and otherwise other trainees on these types of experiences, research or otherwise, that encompass multilingual scenarios. Can you comment on that? One, maybe the first question, I know this is a broad issue, but the first question would be the importance of multilingual public health work practitioners? And then secondly, challenges or wins that you've experienced being one at UNC?
That's a really good question. Something I think about often. So my work, even in the United States, almost all of my studies are mostly in Spanish, in North Carolina too. And so one of the challenges is there are students who would like to work with me, and I'm like, do you speak Spanish? Because my data is in Spanish or things like that. And that can be a little bit hard. But I do think, one, it's a benefit. I work with clinician navigators who are at UNC hospitals, and I'm able to kind of talk with them just in Spanish, be like, what are the needs that you have? And I can connect them with other resources. I can do presentations with community partners around, and they're like, actually, we need someone who can speak Spanish about this, this, and this, and answer questions. So it does allow you to be more available, I think, when you think about community engagement. And also as a university, we are partnering with our local communities, making sure that we're available for students. We actually just had yesterday students from Latin America talk about how they felt very alone because there weren't as many faculty also from Latin America or Latinos in general. And so we're just like, okay, so we have to build community and do it more intentionally. So I think it's helpful for students to see that as well. And then even for students who are not from Latin America or Latinos, but want to work with Spanish speaking populations, I think for them, it provides opportunities. As I mentioned, I'm going down in the summer, but I'm not doing the research. It's actually, I'm bringing 2 students down, and they will be there in the summer for a practicum to do research. I have another practicum in North Carolina focused on prediabetes and stress and thinking about that. Everything I do is bilingual. So every time I work with students now, I'm just like, can you develop this in English and Spanish? Because we need to have both IRBs, everything's in English and Spanish from the get-go. So it's a lot more work, but I do think it makes things a little bit more accessible. I wish I could speak Portuguese. That would be helpful, because it does leave out entire groups from Latin America or like Haitian Creole. But I think it's like, how do I bring that as part of a team so it's a little bit more comprehensive? And that's something I'm thinking about too.
Thank you. We have time for one more question. Do you see it, Dr. Wallace?
I do. Estefania, okay. From the Dominican Republic, practice medicine, sees some of the same taboos about mental health support. Is it likely that these patients would be open to being referred to mental health providers or any mental health support? That is a great question. So there's an entire presentation I could do of all the things that I couldn't put in a study, and they're just on my observation notes. So this clinic actually has the PHQ-2 that they ask patients maybe every 3 months. So the PHQ-2 is just 2 questions that are a screener that then, if you say yes to both, you go to a PHQ-9 on depressive symptoms. And anytime I'm not doing interviews, I actually volunteer in the clinics, mostly to like help them, but then I can observe how they actually are doing things. And I was observing how one of the providers kind of talked someone out of a yes on the PHQ-2, like, do you feel depressed or do you feel really sad? And the person said yes, so you would put a yes, but then they mentioned, but could it have been because of like all these things that just happened right now? Like you can pray about it and things like that. And then the person was like, oh yeah, you're right. So it's a no. So this population is about over 1,000 people, but when I asked about how many actually have depressive symptoms, it's less than 1%, which does not make sense to me. So we're actually going to ask those questions and bring it up to, and again, this gets at the provider side of how comfortable are they with talking about mental health. And also maybe there's churches around, and I talked to the local priests there, and they're actually pretty comfortable with that. I think, how do we get the churches, because people do go to church fairly often, and have them be a support system too, I think would be really helpful. So it is a taboo. I've heard directly from people just like, oh, if you have depression, it's because you are not kind of like aligned with God. Like, and this was like very recently. It's not uncommon. And people will tell me things, and I think it was helpful they see that I'm from the United States, but they know I'm from Panama. So they just are like, you know what it's like. And I was like, no, tell me more. What is it like? But it is a taboo. And I think we just have to create a network where it feels less so and make sure everyone's kind of on a similar page. And I think if we do bring in a counselor, so there's a lot of younger people in that area who are going to college for psychology. So if we can bring a counselor to come in to talk about it, kind of less on like, this is a therapy, more like we need to talk about your health and your emotions, your mental health. I don't think it's that bad. And individuals did talk about depression themselves. We never brought it up. They're just like, yeah, I can feel depressed, or this is causing me a depression. And so I would like to engage and make sure that they feel heard too.
Unfortunately, we are at our time, but this was really excellent, Dr. Wallace. Again, thank you so much for your time. I wish you could hear our applause, but that's one of the disadvantages of Zoom. Thank you so much, and we look forward to having another visit with you in person. I know that you have a lot of colleagues and people you could be working with here as well. So take good care until we see you again. Bye, everyone. Everyone else, I'll see you next week.
Thank you.